This video demonstrates how to use the Avanos CORFLO Safety Pull and Push Peg. The CORFLO peg is intended for the delivery of enteral nutrition, water, and medications into the stomach and will allow gastric decompression or drainage. Caution: the stomach should be kept inflated throughout the procedure to ensure contact of the gastric and abdominal walls. Place an endoscope and examine the stomach and duodenum. Tensely inflate the stomach with air. Dim the room lights and transilluminate the stomach and abdominal wall. Depress a finger at the site of transillumination and endoscopically visualize the finger impression. Place the snare loop at the site of the finger impression. Infiltrate the site with local anesthetic. Following local anesthesia, make an approximately 1 centimeter incision through the skin with the safety scalpel. Warning: for kits that contain a plastic cannula, do not reinsert the needle or any other sharp object into the cannula while the cannula is in the patient. Pass the Seldinger needle through the incision and into the stomach so it can be visualized by the endoscope. Loosely tighten the snare loop around the cannula. Remove the trocar from the cannula and immediately insert the looped placement wire into the cannula. Quickly feed 10 to 15 centimeters of wire into the stomach. Slide the snare loop off of the cannula and grasp the wire tightly. Retract the snare sheath tightly into the scope. Remove the scope and the snare as a unit. Interlock the loops of the peg tube and the placement wire as shown. Lubricate the peg tube. Apply gentle, steady traction to the abdominal end of the placement wire while guiding the peg tube into the patient's mouth. Continue traction until the end of the peg tube is pulled through the abdomen. Continue pulling the peg tube through the abdominal wall until the 15 centimeter mark on the tube is visible. Reinsert the endoscope. Visualize that the bumper has completely re-expanded within the stomach. Cut the placement wire to remove it from the wire loop on the tube. Slide the tube fixation device base and then the tube fixation cover over the entire tube. The base portion goes first. Cut the peg tube to the desired length, at least 2 inches below the dilator portion. Close the Y adapter caps. Untwist the skirt from the Y adapter. Put the peg tube through the narrow end of the skirt. Note: the use of the skirt is vital. It occludes the air lumen, which prevents air from escaping the internal retention bumper to minimize inadvertent removal of the peg tube. Push the peg tube onto the barbed end of the Y adapter. Important: push over the barb until the tube stop is reached. Twist and push the skirt on until the skirt stop is reached. Slide the base of the tube fixation device down the tube, flat surface first, to the abdominal wall. Under endoscopic visualization, position the internal bumper loosely against the gastric mucosa. There should be no blanching of the gastric mucosa. Secure the tube in the groove of the tube fixation device base and slide the tube fixation device cover, pointed end first, down the tube to engage with the base until a click is heard to lock the cover in place. Allow approximately 1 centimeter or 10 millimeters of movement between the base and the abdominal skin. Following gastric decompression, the tube fixation device should not indent the skin. If it does, adjust as necessary. Apply povidone iodine ointment to the exit site. No dressing is necessary. Note: the 20 French tube fixation device has a circular disc. The 12 French and the 16 French tube fixation devices do not have the circular discs. An optional silicone T fixation bar with retention sleeve is included. This T fixation bar is provided as an alternative to the tube fixation device. Warning: excessive traction may cause premature removal. Use of the peg tube may commence 4 hours after insertion, usually starting with sterile water. Refer to local policy. Procedural steps for the push technique are the same as the pull technique until the guide wire is being pulled from the mouth. At this point, complete the following steps. Ensure the guide wire is viable at both entry and exit points. Straighten the tapered dilator portion of the tube prior to sliding it over the guide wire. Lubricate the PEG tube and the tapered dilator. Advance the dilator tip over the guide wire. Firm tension must be applied to both ends, entry and exit, of the guide wire as the tube passes into the oropharynx. With the guide wire under tension, the dilator tip will meet the needle cannula and push it through the anterior abdominal wall. After the dilator portion exits the abdominal wall, remove the guide wire. Note, the guide wire may remain in place if desired for reintroduction of the endoscope over the wire. The wire must be removed before the tube is cut. Continue by pulling the PEG tube through the abdominal wall until the 15 centimeter mark on the tube is visible. Procedural steps to secure the PEG are the same as the pull technique referenced earlier.